ওকে, রেসপেক্টেড ফিজিশিয়ানস, সবাইকে আজকের ওয়েবিনারে স্বাগতম। আজকে আমাদের টপিক ভালভুলার হার্ট ডিজিজ পার্ট 1। আজকে আমরা অত্যন্ত সৌভাগ্যবান, আমাদের মাঝে আছেন আন্তর্জাতিক খ্যাতিসম্পন্ন কার্ডিওলজিস্ট ডাক্তার চৌধুরী এইচ আহসান স্যার। ডাক্তার চৌধুরী এইচ আহসান ক্লিনিক্যাল প্রফেসর অফ মেডিসিন, ডিরেক্টর কার্ডিয়াক ক্যাথেটারাইজেশন অ্যান্ড ইন্টারভেনশন, ডিরেক্টর কার্ডিওভাস্কুলার রিসার্চ, ইউনিভার্সিটি মেডিকেল সেন্টার, লাস ভেগাস, নেভাদা। এবং আমাদের সঙ্গে আছে চেয়ারপারসন হিসেবে উপস্থিত আছেন ডক্টর রফিক আহমেদ। ডক্টর রফিক আহমেদ কনসালটেন্ট, কার্ডিয়াক ইলেকট্রোফিজিওলজিস্ট, মেডস্টার হার্ট অ্যান্ড ভাস্কুলার ইনস্টিটিউট, বেলটিমোর, ইউএসএ। এবং আজকে আমাদের মাঝে চিফ গেস্ট হিসেবে উপস্থিত আছেন প্রফেসর ডক্টর মাহমুদ হাসান স্যার। প্রফেসর ডক্টর মাহমুদ হাসান স্যার এক্স ভাইস চ্যান্সেলর বিএসএমইউ এবং এক্স প্রেসিডেন্ট বাংলাদেশ মেডিকেল অ্যাসোসিয়েশন। আমরা শুরুতে একটু সংক্ষেপে আমাদের আজকের স্পিকার সম্বন্ধে একটু বলে নিই। প্রফেসর চৌধুরী এইচ আহসান passed MBBS from Dhaka Medical College and awarded the gold medal in medicine. He completed PhD from University of Southampton in UK for his research in the ethnic variation of the pharmacokinetics and pharmacodynamics of calcium channel blocker. Completed postgraduate training in internal medicine and cardiovascular diseases in the University of Pennsylvania and Drexel University College of Medicine, and did his international cardiothoracic fellowship in the Mount Sinai Medical Center. He is board certified in internal medicine, cardiovascular medicine, nuclear cardiology, and interventional cardiology. Dr. Ahsan contributed significantly for the establishment of Shandhani, a voluntary organization of the medical and dental student, and become Secretary General of the Shandhani. He is awarded prestigious Las Vegas Hills Award. He is named WHO's WHO and also enlisted in World Leaders in Medicine. Dr. Ahsan recently been elected the Governor of Nevada Chapter of American College of Cardiology. আরো অনেক বড় প্রোফাইল, কিন্তু যেহেতু আজকে অলরেডি আমরা লেট, আমরা সংক্ষিপ্ত করলাম। আমি আজকে যেহেতু চেয়ারপারসন এখন রিচ করেননি, আমাদের আজকের চিফ গেস্টকে আমি অনুষ্ঠানটি শুরু করার জন্য আহ্বান জানাচ্ছি।
ধন্যবাদ
প্রফেসর মাহমুদ
এহসানুজ্জামান খান সাহেব। আজকে সবাইকে আমি স্বাগত জানাচ্ছি। প্রফেসর চৌধুরী হাফিজুল আহসান সাহেব অত্যন্ত আপনার দক্ষ এবং কার্ডিওলজিস্ট, যিনি আমেরিকার সারা বিশ্বেরই সামনের সারির একজন বলা যেতে পারে। এবং তিনি যে এত ব্যস্ততার মধ্যেও বাংলাদেশের জন্য সময় দিচ্ছেন, অবশ্যই এটা উনি দিয়ে থাকেন। বাংলাদেশে উনি দীর্ঘ অনেক বছর যাবত প্রায়ই আসেন এখানকার কার্ডিওলজিস্টদের দক্ষতা বাড়ানোর জন্য। তো আজকে আমাদের সৌভাগ্য যে আমরা ওনার কাছ থেকে ভালভুলার হার্ট ডিজিজ সম্পর্কে শিখতে পারবো। আমি ধন্যবাদ জানাচ্ছি এবং কৃতজ্ঞতা জানাচ্ছি প্রফেসর চৌধুরী হাফিজুল আহসান সাহেবকে তার এই সময় দেওয়ার জন্য। এবং আমি সবাইকে বেশি সময় নষ্ট না করে, যেহেতু আমরা অলরেডি একটু লেট হয়ে গেছি, আমি শুরু করার জন্য আহ্বান জানাচ্ছি। ধন্যবাদ।
Thank you. Good morning, everyone. It is a distinct honor and privilege to be invited in a forum like this and talk a little bit about cardiology. And I particularly thank Professor Mahmoud Hassan, and it is really a huge honor, and it means a lot to hear some kind words from someone like him. So I'll make it a little faster because we are running a little late because of the connection issues. I did talk to Dr. Ahsan Khan and Dr. Rafiq Ahmed. We decided that we'll do this in a few parts, maybe 2 or 3 parts, to cover the valvular heart disease. This is a huge subject, but I will start with a case. Maybe we can interact if possible. This is an 82-year-old male presents with exertional dyspnea and lower extremity edema. Physical exam reveals 4/6 systolic murmur at the right upper sternal edge, and there is audible with no audible S2 sound. The murmur radiates to the cardiac apex where it sounds holosystolic but does not increase with hand grip maneuvers. The carotid upstroke is weak and delayed. Echocardiography confirms the presence of aortic valve stenosis with a mean pressure gradient of 45 millimeter mercury and aortic valve area of 0.8. So this is typical presentation of aortic stenosis with pulsus parvus and pulsus tardus. And the murmur that we are hearing in the apex is not a separate murmur. Sometimes we hear that murmur of aortic stenosis, which is best heard in the parasternal edge or in the aortic area, but can be heard in the apex, which is called the Galiverden sign. And in the presence of parvus and tardus, if it is severe AS, then the S2 often is muffled. So this is typical of severe aortic stenosis. So if someone asks you about the degree of aortic stenosis clinically, this is severe aortic stenosis. Why we need to know about aortic stenosis? Because it has significant morbidity and mortality. If we look at this second patient, 72-year-old male, obese, with dyspnea, edema, 3/4 systolic ejection murmur, radiating to the carotids. S2 sound is audible, but soft. An echocardiogram revealed normal LV function and a mean gradient of 30. The aortic valve area, same. Which of the following is most appropriate? Similar patients, one is moderate aortic stenosis. In cardiology, we do a mean gradient of more than 40 to call it severe. Valve area calculation is complex, and valve area, if calculated wrong, can mislead you. In this case, what are the options we have? Surgical aortic valve replacement after coronary angiogram, cardiac catheterization for hemodynamic assessment of the aortic valve, and then transesophageal echo, medical therapy, and repeat echocardiogram in 1 year, and treadmill stress test. I would ask Dr. Ahsan Khan, who is moderating, do you want to discuss this? Anyone to jump in, or I will go on?
স্যার কেউ যদি মানে হ্যান্ড রাইজ করে কথা বলতে চায় আমরা খুশি হইতাম স্যার। ডক্টর মাইসুম সোবাহান।
স্যার বুঝতে পারতেছি না স্যার, স্যার কন্টিনিউ করুক স্যার।
আচ্ছা স্যার তাহলে একটু কন্টিনিউ করেন স্যার।
So this is moderate aortic stenosis, and you can do further assessment by doing cardiac catheterization, right heart catheter and the left heart catheterization, see the gradient, look at the coronary angiogram, and go from there and decide. So the burden of the disease, the aortic valve stenosis, as we grow older, there is more likelihood that we will see a significant increase in the aortic stenosis. And then if you see the survival, once the symptoms appear, the survival of the aortic stenosis can be abysmal. And if you look at this age group of this study, that really see that if the patient is more than 75 years old, and if you look at 70 above, about half of the patients in the aortic stenosis group are above 70. So it is a disease of the elderly. And if you look at, compared to that, mitral stenosis, vast majority of the mitral stenosis is below age 70. And mitral regurgitation, which will be my next topic if we have time, also a significant proportion come at the later age. In Bangladesh, for example, aortic stenosis can be difficult because it is a difficulty in decision making. There is increased operative risk, and I would say intervention risk, because now transcatheter valve is available. It is expensive, but the procedural risk can be less, and there is a huge cost involved. And then question remains that if it is the disease of the elderly, how much we spend out of pocket for that intervention, and then do we have the logistics, the infrastructure, the follow-up care, the dedicated valve clinic, and more importantly, ensure that the follow-up care is done. Another important thing that we have not developed a systematic heart failure clinics. We need that, and a significant proportion of patients in the heart failure clinics actually have valve disorders, something we need to think about in Bangladesh. So aortic stenosis, as I told you, that with increasing age, there is higher number. This is the statistics from Europe. Up to 7% of patients above 65 can have this aortic stenosis. So what are the causes? It could be calcific aortic stenosis, rheumatic fever in the past, but isolated aortic valve without mitral valve involvement is rare. And if you see someone with mitral valve, chronic rheumatic disease, and in addition, aortic valve, it becomes complicated. And then rarely we can see bicuspid aortic valve that over time can give aortic stenosis. So this is very important to see these pathologies, and then it is really a fixed obstruction. As the aortic valve area reduces, the Doppler signal gets worse. And this is what we call the aortic valve continuous wave Doppler. This is from here to here is called the peak gradient, and that is more than 4 meters per second, signifies severe aortic stenosis. If you do the area under the curve of the Doppler, you get mean gradient. And in the studies, for a variety of reasons, mean gradient more often used than peak gradient. On the top, you can see how the cholesterol, the LDL oxidation, and subsequent inflammation, pretty much like the atherosclerotic disease, can also contribute to the development of fibrocalcific aortic stenosis. In dialysis patient, we often see there is dystrophic calcification and then progression of the aortic valve and aortic stenosis. So this is the normal cusp, and with the fibrosis and calcification, over time, that valve becomes narrower and causes the obstruction, giving rise to the aortic stenosis. So increasing age, male gender, hypertension, smoking, high cholesterol, that can give you the aortic stenosis. But more importantly, if somebody has congenital bicuspid aortic valve, that can over time give calcific aortic stenosis. And we need to also pay attention to the coexistent aortic regurgitation and also the aortopathies that can be coming with this. So it is very important. This is the famous publication from Dr. Bronwall from Boston that says that if someone has aortic stenosis and in latency for a while, and we don't diagnose, and then once they start developing symptoms, and the three cardinal features are the shortness of breath, heart failure, loss of consciousness, transient, reversible, syncope, and then the angina without any coronary artery stenosis. In case of patients with, remember, these are the elderly patients with severe coronary artery disease along with severe stenosis, the prognosis can be even worse. So once the symptoms appears, this patient crash very rapidly. And therefore it is important to identify them earlier and then provide a therapy, which is pretty much basically an intervention, because medical therapy does not do much because this is a fixed obstruction and we can deliver the care. So the overall prognosis, if we think about this is a sobering perspective. If you look at the other malignant diseases, versus the severe inoperable aortic stenosis, the 5-year survival is pretty abysmal, less than 5% compared to anywhere between 5 to 25% in other malignancies. So it is pretty bad news once we see severe aortic stenosis with symptoms. And this is the current guidelines in terms of defining aortic stenosis: mild, moderate, severe. Someone in the mild, moderate group without any coexistent LV dysfunction on coronary disease can be followed up closely and then intervene when needed. We can pick up this carefully by history, physical exam. The EKG often shows LVH. Patient can go into atrial fibrillation easily. LVH can give diastolic dysfunction, and they can have paradoxical, what I call the paradoxical low flow, low gradient, because there is diastolic dysfunction. And because of the diastolic dysfunction, the stroke volume may fall, low flow, and they may not generate enough gradient. That is called the paradoxical low flow, low gradient. I'll touch base on that in a second. And then they can develop the LV remodeling with LVH, and the LV starts dilating. Once the LV starts remodeling, then it is even worse. And those patients with LV dilatation, LV systolic dysfunction, and severe AS, their prognosis can be really poor. Often we need to see the aorta also, particularly in the case of aortic valve bicuspid, where there is aortopathy. And when we do intervention, we may need to take care of the aorta and along with the valve for the aortic root replacement and the valve replacement. The Doppler I mentioned earlier can give the high velocity across the aortic valve. And with the Bernoulli equation, we can calculate the pressure gradient. And if the pressure gradient is more than 64 peak velocity, which is 4 meters per second, can be signifying the severe aortic stenosis. Or we can calculate the mean gradient, which often more used in the studies. So this is the Bernoulli, the continuity equation. If we know the velocity at the valve, we know the velocity at the aortic outflow tract, and we know the aortic outflow tract area, we can calculate the aortic valve area. So the aortic outflow tract area we know the velocity here, and we know the velocity of the aortic valve. We can put these together in the Bernoulli equation because flow here and flow here will be same. The aortic outflow tract flow and the aortic valve flow should be same. And if we do the continuity equation, we can figure out the aortic valve area. But why I'm showing you this? Because you may not be doing echo, you may not be involved in cardiology, but you need to know, because the LV outflow tract area, this diameter measurement, this measurement, if it is wrong, the valve area calculation will be wrong. You may get a tighter valve, but in effect, it is not. So you need to pay attention to the valve velocity, if it is more than 4 or the mean gradient 40 or not, because that will tell you. And then you have the patient in front of you, and then you decide. There are many ways to look at the valve, the morphology of the valve. You can do the valve area calculation. We don't really recommend that because the valve area by planimetry may not be the best way to measure. In the cath lab, what we do is we measure the aortic pressure, and then we measure the LV pressure. The LV peak pressure and the aortic peak pressure, we call that the peak to peak gradient. Often this is delayed and can be misleading. Therefore, we do is the shaded area under the curve, kind of similar as we know from the Doppler. The shaded area, the area under the curve between the LV and the aortic pressure. We call that mean aortic gradient. And there is formula for that, calculation of the aortic valve area. In the cath lab, we call that the Gorlin's formula. Unless you are pursuing career in cardiology, you probably don't need to know that. But this valve area calculation is dependent on the cardiac output. Cardiac output is stroke volume times heart rate. So if the heart rate is similar for the equation in the Bernoulli, then stroke volume that matters to define the velocity. Meaning, if the stroke volume is less, obviously the Doppler velocity will be less. In that situation, we need to do something to increase the flow by dobutamine, increase the flow, and then calculate. And these are called not so classic aortic stenosis. And we need to know that. Why? Because if the LV function is bad and the aortic stenosis is moderate, maybe it is moderate because the calculation is not right. We need to give dobutamine, increase the flow, and really see that the stenosis is severe, or we see that the stenosis is actually mild. So we should not be sending someone for surgical or, for that matter, percutaneous valve implantation when the patient does not need it, because the aortic stenosis indeed was mild and could wait before we go for intervention. Similarly, patient with LVH and diastolic dysfunction can have a small stroke volume and also can show low gradient, but falsely giving a tighter valve area. So we need to be aware about this entity. This is the cartoon showing that same phenomena. In the case of low flow, low gradient, you need to at least get cardiology referral and evaluate the valve and see whether intervention is needed. I would request you to look at this the valve guidelines, because it actually involves the internal medicine, primary care doctors of other specialties to be aware that stage A, those who are susceptible for developing aortic valve stenosis, has not developed any significant AS yet. Stage B, they have a stenosis, they're progressing. C, they have now severe stenosis, can be asymptomatic, can be symptomatic with LV dysfunction, or symptomatic with LV diastolic dysfunction. So pay attention to this, the valve guidelines and the staging system. At least you have an idea that what the societies are trying to do, make you aware about aortic stenosis, identify the patients at risk, and then define at what stage they are, and then do the proper evaluation for management purposes. And this is pretty much same that if there is aortic valve stenosis, mostly you can look at this survival curve, that if it is needed, class 1 indication or class 2A indications, then intervention is appropriate, and you will be doing a disservice if not referring this patient or treating these patients for the survival benefit. There are many ways we can do the aortic valve replacement. This can be prosthetic valve, mechanical, which warrants anticoagulation, and anticoagulation until today is coumadin, not the direct oral anticoagulants or the newer anticoagulants, because they are not helpful for the mechanical aortic valve patients, because this anticoagulation has to be vitamin K antagonists. The Bio-prosthetic valve, tissue material, and you can continue with the antiplatelet agents and do not need long-term anticoagulation. And these are either replaced by surgically or by percutaneous aortic valve implantation. These are several varieties. Over the years, we have developed this balling cage, now replaced by tilting disc, Bio-prosthetic valve. They may have a ring, they may have a stent struts, but overall, the prognosis after the valve replacement is really, really good. So in the case of transcatheter valve, we basically put a catheter in the aorta and then put the wire into the LV and then implant the valve by balloon inflation, make sure that it is not obstructing the coronaries. And there are many ways to do this. Currently, there is a Situaion valve and the Medtronic valve. We are using both. And there are many ways to make sure that the access, the femoral is good. Then the valve calcification is defined by the CT angiogram, the measurements of the sinus of Valsalva and the valve, the aorto-sinotubular junction is defined, and the coronary vessels orientation also defined, and then coronary angiogram done, and the valve implanted appropriately. So I tell you this, that we have come a long way. In the original partner trial, where they actually challenged this valve in the high-risk group, where it is inoperable, and the high-risk group where it is operable. So in the cohort A, they did the operable group, so they go randomized either TAVR or SAVR, surgical. And in the inoperable group, which is cohort B, their natural history, as I told you, survival is so poor, and they did the TAVR valve and see what happened. So in the partner trial, cohort B, these are the patients who are inoperable, old age, frail, calcified, bad lungs, renal function problem, poor candidate surgically. And look at this. This is one of the important survival curve in cardiology, and I would actually say in medicine. Over 24 months, only 24 months, those patients who did not have any intervention, so-called medical therapy, which is pretty much useless in the fixed aortic valve obstruction that we are dealing here, the mortality was as high as 68% versus 40% in the cohort B who received the TAVR. So absolute, not relative, the absolute, we know now by the COVID-19 trials that what relative risk reduction means, because even Food and Drug Administration Commissioner Steve Hahn screwed up because he was claiming 33% relative risk reduction, which means nothing unless you see the raw data. But here I am telling you that this is absolute risk reduction about 20%, which means 1 in 5 number needed to treat is 1 in 5 to actually help survival. This is one of the most powerful tools in medicine that we have seen with implantation of the aortic valve. And I'm not even mentioning the other net benefit in terms of quality of life, in terms of reduction in heart failure admissions, in terms of improving the heart failure class after the aortic valve implantation. It does come with cost, and the cost is bleeding, and the cost is stroke, but we are developing. We are developing this much better designed valve, the Sapien valves, now Sapien 3. And if you look at this cohort A, where it was SAVR versus TAVR, the mortality was identical. So it was challenged with the SAVR in those who are operable. And of course, the patient now are choosing the transcatheter valves. So this is very important to understand that we need to identify this deadly disease, and we need to identify at what stage of this disease the patients are, and when to refer, and how to evaluate, and how we can deliver the therapy that is needed, and then we'll really provide the standard of care. So let me finish this part with this case. And I really would like to have some audience participation in this. 84-year-old oxygen-dependent lung disease, chronic kidney disease, mild dementia. Family claims that the patient has otherwise good quality of life. We need to pay attention, tell these fellows and residents that we also need to justify when we deliver the care in the elderly that there should not be like a therapy and we don't ask the question of futility of care. So we need to be careful about when we talk about therapy. In any case, this patient had a reasonable quality of life, diagnosed with colon cancer and after lower gastrointestinal bleeding, and is going to require surgical colectomy. Preoperative examination reveals 3/4 systolic murmur. Echocardiography reveals critical aortic stenosis mean gradient of about, let me see this, 75, which is severe, and then valve area is 0.6. What is the most appropriate treatment plan? Proceed with colectomy with understanding of high cardiovascular risk, balloon aortic valvotomy, surgical aortic valve replacement prior to colectomy, and cardiac catheterization, right and left heart catheterization, coronary angiography. Anyone?
Sir, Dr. Shourav Das. Dr. Shourav Das, please. Sir, Dr. Shourav Das, our hand raise korche.
Okay, Dr. Shourav Das. Thank you for volunteering.
This is
Dr. Shourav, please.
So this is probably a case of Hayes syndrome, aortic stenosis associated with angiodysplasia of the colon. In that case, surgical aortic valve replacement prior to colectomy should be preferred option, as because if the aortic stenosis remains, RBC when going through the stenosed area predisposed to lysis.
Yeah. So, Dr. Shourav, thank you. So this is the challenge, and that's why I put this case. So they are asking for a preoperative evaluation, correct? And you know that the surgical risk for aortic valve replacement is huge. The patient has colon cancer, and we know that this is Hayes syndrome. And since I started going to Bangladesh, since like 2004, I actually tell my fellows that I am challenged with more data, I'm challenged with more information, because we need to provide the practical thing that we can do in Bangladesh. And if you look at the American College of Cardiology pre-op evaluation guidelines, which is supported by the American Society of Anesthesiologists, in this case, you really don't need anything, because what is the most urgent thing is the colon cancer and the resection. And aortic valve stenosis is there, but the patient is not in active heart failure, and there is no active emergency here. And aortic valve valvuloplasty, you can try to do, but in case you end up with aortic regurgitation, this patient will need aortic valve replaced surgically, and then can be a disaster. And cardiac catheterization is only to derail you, because unless you are planning to do aortic valve replacement, there is no need for cardiac catheterization. I tell this all the time. Cardiac catheterization laboratory is not a photography lab. You go there because you have a plan to do something. In this case, we don't need anything. We just proceed with colectomy with understanding of high cardiovascular risk. And everything Dr. Shourav Das said, this patient has Hayes syndrome, and the valve replacement actually may help to reduce the bleeding. And you know that there is changes in the expression of the von Willebrand factors, and valve replacement will change all that. So it is very important. Pre-op evaluation, if we know the disease, you know the natural history, you know the options, then in this case, people will laugh at you, but please don't. Let them understand that proceed to colectomy with understanding of high cardiovascular risk. Another important thing, if the patient needs GI endoscopy, this patient is okay to go for GI endoscopy. I often tell my GI doctors here that GI procedures are not operation. See, if it is not op, there is no pre-op. I call it procedure, and most of the time, the GI procedures are okay, and you need to talk to the anesthesiologist to be in sync with you, because anesthesiologists are the one who actually oppose you for the procedure. 81-year-old female with a history of severe asymptomatic aortic valve stenosis, presents with recurrent gastrointestinal bleeding. Upper and lower GI endoscopy have not been able to reveal the etiology. Capsule endoscopy reveals small intestinal dysplasias, right? That was this patient, right? And we discussed that this is all about Hayes syndrome. The gastrointestinal bleeding may resolve after the aortic valve replacement. True, Ball-Willy-Brandt factor, and I told about that, Hayes syndrome. So all of the things are above are correct. Any comment so far?
Sir, thank
Because
you.
we are already like
Very informative presentation.
8:55. So, sorry?
So thank you, sir. Very informative presentation.
Sir, I
Yeah,
have a
so
query.
Yeah, go ahead.
The previous one, not the 81 years one, the one before that, the colorectal cancer, we will directly proceed to colectomy. That is the answer that I understood. But this patient has colon cancer. So, is it for the Hayes syndrome or this is a separate entity?
Oh, this is the 84-year-old is
Yes.
colon cancer, and you cannot tell. You can suspect whether there is any angiodysplasia as well. You know, I can't tell.
Okay.
But you brought up this issue that Hayes syndrome. That's why I put the case that Hayes syndrome can present with bleeding and no cancer. But in the in this patient, it may be or may not be. We don't know. But it may be
Okay.
all because of the colon cancer. Yeah.
Okay. Thank you, sir.
স্যার কিছু কোশ্চেন কি নেওয়া যাবে স্যার?
Yeah, definitely.
ডক্টর মেসাম সুবহান।
জি স্যার, আসসালামু আলাইকুম স্যার।
Yeah.
স্যার, এই আমার কিছু কোশ্চেন স্যার, যে পেশেন্টের লাইফ এক্সপেক্টেন্সি কি রকম যদি একটা পেশেন্টের অ্যাওর্টিক স্টেনোসিস থাকে এন্ড সিনকোপ থাকে, যদি অ্যাওর্টিক রিপ্লেসমেন্ট না করতে পারে?
So I showed you the slide, right? This is Dr. Eugene Braunwald's work in mid-60s when he showed the survival curve that they have a latent period with the aortic valve stenosis and progression. And then once they develop these three symptoms, the one is shortness of breath, dyspnea with edema and the heart failure, then the prognosis is pretty bad, couple of years, then syncope about roughly 3 years, and then angina maybe 3 to 5 years. So once syncope starts, the pretty much survival is almost limited to the following 3 years. And if you saw in the partner B cohort that once they are in advanced stage of the disease and they have comorbidities, in about 2 years when they did the analysis, the 2/3 of the patients were dead. So this is pretty bad disease.
Yes,
So
sir.
I
Thank you,
would
sir.
argue this because you mentioned this. I would ask the question about the quality of life. I would ask your best guess about the survival. If the patient has otherwise no comorbidities and the survival is good, if you put this aortic valve issue aside, and the patient, like patient plays golf, enjoys life, has a good time with grandchildren, and the patient, the only thing you discover is the aortic valve stenosis, I think by all means we can target the aortic valve intervention to improve survival. If the patient is dementia, no quality of life, on bedridden, then you may not be able to justify the aortic valve intervention because it's really futility of care. Does it answer the question?
ইয়েস স্যার, থ্যাংক ইউ স্যার। স্যার আরেকটা কোশ্চেন ছিল স্যার, এমন কি কোনো ফার্মাকোথেরাপি আছে যেটা অ্যাওর্টিক স্টেনোসিসের মর্টালিটি রিডিউস করবে?
So the simple answer is no, because this is a fixed obstruction. However, you can buy time by so-called tuning up. And sometimes we do that, correct? If the patient has heart failure, you can give diuretics, decongestion. If the patient has aortic, the atrial fibrillation, heart rate going fast, patient has diastolic dysfunction, you can control the atrial fibrillation ventricular rate. You can even cardiovert, but these are not going to help the underlying pathophysiologic basis of the problem, right? So you buy time, you control the heart rate, you decongest, and then you try to minimize the symptoms, but it's not going to take care of the underlying issue. And therefore, none of these so-called medical therapy did alter the natural history.
স্যার আমি ডক্টর মাহমুদুল হাসানের দুইটা কোশ্চেন একবারে নিয়ে নেই স্যার, তারপর স্যার নেক্সট পার্টে যাব। স্যার, is there any role of reduced HDL over valvular heart disease? First question. And what are the clinical signs where we know surgery is only option for valvular heart disease?
Okay, so sir, the first question is the alteration of the LDL HDL ratio. There is a group from UPenn who had looked into this. We kind of know that the LDL oxidation can play a role, but there is no study yet to show that lowering the LDL, or for that matter, giving HDL supplement. We are now participating in a trial called AEGIS-2 where we are infusing ApoA. Even I asked them, and there's no plan for doing that study in the aortic valve stenosis. The main thought process here that once this is done and advanced, it is very difficult to reverse by changing the lipid milieu. About the surgical question, there are situations where many will opt for a surgical replacement of the valve if there is the following issues. One, concomitant aortopathy and severe aortic regurgitation. But these are all relatively speaking, because it depends on the TAVR implantation center, the experience of the operator, and whether they will be using off-level or not. But there is no recommendation for TAVR percutaneous valve in coexistent aortic regurgitation. Bicuspid valve is okay. And then more importantly, if there is significant left main or multivessel disease that cannot be fixed percutaneously, then surgical valve replacement will be optimal. But it all depends on what are the issues in terms of comorbidities of the patient. And on a smaller note, patient's choice.
Thank you, sir. এখন আপনার next part.
Do we have time for the next?
স্যার আপনি আরো 30 minutes করেন স্যার, কোনো সমস্যা নেই।
Okay, so mitral regurgitation. This is another important issue. 55-year-old with acute onset chest pain and diaphoresis. His EKG reveals acute MI. Emergency intervention is performed, treated and discharged in stable condition. 5 days later, he found unresponsive, brought to the emergency room. Temperature okay, blood pressure now low, and this is hypotension, heart rate 120, respiration high, no murmur is appreciated, and the exam reveals lung fields and with the rails, and stents are patent. And importantly, recent MI, but now the LV function is hyperdynamic, and we do right heart catheterization. Pulmonary capillary wedge pressure is elevated, and there is a large V wave in the pulmonary capillary wedge pressure, which is indicative of more than 2 to 3 times, can be indicative of ventricular septal rupture, non-compliant LV, or papillary muscle rupture and mitral regurgitation. So anyone can guess what is the most likely diagnosis in this patient? Acute ventricular septal defect, free wall rupture causing cardiac tamponade, acute mitral regurgitation, or aortic rupture.
Sir, acute mitral regurgitation?
Yes, this is actually classic case of acute mitral regurgitation, ischemic etiology. we know that there are two PAP muscles, right? One is the anterior and the anterolateral and the posterior medial. And this patient had recent MI and got this intervention, but subsequently have PAP muscle rupture and developed this acute mitral regurgitation. So it is important to identify this. This is a surgical emergency and need to be identified if we want to make change in the survival. 50-year-old with history of idiopathic dilated cardiomyopathy. Over the past 6 months, she has become increasingly short of breath and has been requiring higher doses of diuretics. Echo EF is 20%. Severe central mitral regurgitation is present. She's optimized on ACE, beta blocker, spironolactone, and digoxin. EKG shows left bundle. Which of the following is the next appropriate course of action? Mitral valve repair or replacement by ventricular pacing, add nifedipine for further afterload reduction, and the Alfieri stitch.
Sir, mitral valve repair or replacement?
Okay, so this is not so straightforward, right? Because
anyone, Dr. Nazma Azim? Dr. Nazma Azim?
We have, sir, biventricular pacing.
Biventricular pacing.
Sir, Assalamu alaikum.
Yeah.
হ্যাঁ বলেন।
In this case, I want to add the nifedipine for further afterload reduction.
Okay, so I'm actually glad that we divided the audience nicely. So about the question of afterload reduction, these were actually studied, and the natural history tells that this strategy of afterload reduction in chronic mitral regurgitation, because we can all agree that unlike the first patient, this is actually chronic mitral regurgitation. So in the chronic setting, the afterload reduction strategy did not change in the natural history. So that is not going to be acceptable nowadays. And then the question is, biventricular pacing, some would argue that, yes, I actually need a CRT. What about different? I actually left it out deliberately like this because I thought Rafiq Bhai will be here so we can discuss. So this patient may even qualify for the ICD because over 6 months we are observing and the EF did not change, and therefore it is ideal to give the defibrillator therapy, but give by V the CRTD so that the patient can benefit not only in terms of from the sudden cardiac death, but there is plenty of data now showing that it may change the mitral regurgitation. Mitral valve repair and replacement is an option, probably ideal, but it will be really something brave to do this at this point with the functional MR, which is severe, and LV function is already so poor, there will be a bad course because once you replace the valve, the LV was actually contracting against a low pressure sink. Now you close the valve, the LV will be struggling with a huge workload, and therefore the LV will deteriorate further. And that strategy may be a problem unless a center that has left ventricular assist device to support that time period when the LV deteriorates. So that actually takes me to this slide that we need to understand the mitral valve and then think about how to modulate the hemodynamics. Because the hemodynamics in cardiology, I call it preload, afterload, and cardiac contractility, and the heart rate. These are the 4 pillars of cardiac mechanics: preload, afterload, heart rate, and contractility. Unless we understand the mitral valve and the origin of the mitral valve regurgitation, we will not be able to use those 4 fundamentals to manipulate and then decide about when to go for intervention. Example, the leaflet, 2 leaflets, anterior and the posterior. The posterior has scallops, P1, P2, P3, in the degenerative mitral valve or the Barlow syndrome, where you see this myxomatous valve, you can see that the P2 scallop is typically affected. And in those cases, you can give an Alfieri stitch like in the midpoint and then make it almost like a midpoint closer, and then the regurgitation significantly goes down. Nowadays, we are doing that same thing with the mitra clip and reduce the mitral regurgitation. For the scallops, we also divide arbitrarily the anterior scallops A1, A2, A3 for anatomic purposes. So there can be problem in the leaflet. Leaflet can be perforated. Leaflet can be tethered, and leaflet can have problem with the commissure. Hallmark in rheumatic valve disease is the commissural thickening, and the annulus can be affected. The whole annulus can be calcified, and that we see in the dialysis patient. Or there can be chordae tendini problem. There can be chordae tendini micro rupture. There can be chordae tendini rupture, or there can be subchordal apparatus, pap muscle rupture, or even sometimes pap muscle dysfunction because of the ischemia. And then that can give the mitral regurgitation. And then if you think about the LV geometry, LV remodel, and whole geometric change in LV can be such that the posterior mitral valve leaflet can be tethered, and there can be the production of a significant mitral regurgitation, often an eccentric jet. And the LV function is also important to determine the jet velocity and the degree of the mitral regurgitation. So all these are important. And all these are important when we talk about the mitral regurgitation, and then what is the etiology. So acute mitral regurgitation we see often with acute MI and also in endocarditis. Malfunction or disruption of the prosthetic mitral valve. We call it blow up of a valve, and you need to know where is the problem. Paraprosthetic leak in a mechanical mitral valve can be a disaster, but we need to identify. Sometimes you may not hear the murmur that often because the severity is such that there is no flow and you may not hear it, but you need the imaging tools, particularly transthoracic, may give you a clue and immediately get a transesophageal echo and understand the origin of the mitral regurgitation and the severity. So endocarditis is a big issue, and acute MI, as I shown in the case, these are all important issues, and where we can use the afterload reduction, and then if possible, some support with balloon pump. And afterload reduction, remember, can help, as one of our attendees pointed out, but it is all transient to salvage. But we need to go for the mechanical correction of the valve. So, and we don't need to give beta blocker in this situation because tachycardia is, remember, stroke volume times heart rate. Stroke volume is interesting because the LV is trying hyperdynamic, but many of this LV generation of total stroke volume is going to left atrium. The systemic stroke volume, that means amount of blood per heartbeat going to the aorta, is actually less. Stroke volume is less. And therefore, if you reduce the cardiac, the heart rate, then the total cardiac output will be low and the systemic perfusion will be low. Therefore, you try this tachycardia to continue and do something to reduce the afterload, give something like balloon pump, but more importantly, address this issue with emergency surgery. On the other hand, chronic mitral regurgitation, patient can tolerate, patient will tolerate, but they cannot tolerate for too long and they will deteriorate. And therefore, it is important to understand that once they deteriorate, once the LV starts remodeling, once the LV function deteriorates, it is difficult to take care of this mitral valve regurgitation. And I would request you to understand that that there could be primary pathology of the valve in chronic situation, which is primary mitral regurgitation, or it can be secondary, that LV is dilated for any other reason, LV dilatation, geometric change, and then develops this problem of coaptation of the valve, and that is called the secondary mitral regurgitation. It is critical to understand the primary and the secondary issues of the mitral valve regurgitation, and then define the severity, and then after that, think about what to do. There are many ways you can do this. Understanding of the pathophysiologic basis and alter the pathophysiologic basis and work on the hemodynamics. And by time, you do have time, but not that for too long. One of the important things for the physical exam, that if you hear the S1 is muffled, there is trouble. That means in the presence of mitral regurgitation, S1 soft, not loud, is indicative of the LV systolic function. LV contractility, LV contractility is actually getting worse. And then presence of S3 means simply in the adult that left ventricular end diastolic pressure is elevated. It's very important to pay attention to that. And then you can check the apical impulse. LV will be dilated if the apical impulse is shifted. And then if you see the subsequent issues such as lung crackles, then elevated jugular venous pulsation, that means the right side now affected, and then sacral or decubitus also edema or leg edema, that the right-sided pressure is also elevated. Hepatomegaly, pulsatile liver, these are all bad, because in the presence of severe MR, if the right side also affected and there is severe pulmonary hypertension, then it is very difficult to bail out these patients even by surgery. Often they develop tricuspid regurgitation, and then you need to do tricuspid ring repair. So in addition to the valve, you need that, and that makes the surgery more difficult. So natural history of the MR is not any better than aortic stenosis. That can be, but patient can tolerate little longer, but eventually this will be worse. And we have all these modalities to assess the initial EKG, the chest X-ray, the echocardiogram. You can see in the EKG, in the presence of mitral regurgitation, which is bad. The atrial fibrillation is a bad news. And because of the LV dilatation, there may be LV hypertrophy. And once there is LV hypertrophy, and this same patient with LV hypertrophy, you are losing voltage in the subsequent visit. That means that LV, there is muscle loss. That means LV hypertrophy, which was once hypertrophy, and losing the voltage, that the patient is progressing towards end-stage cardiomyopathy, and you will soon see them to show a restrictive pattern. So this is the grading of the severity. You probably don't need to know all this unless you are in cardiology, but it is critical that we define the mild, moderate, severe. We also quantify them if possible, because if we look at the SAFE trial, the survival after ventricular enlargement following MI, those who had MR versus no MR, the MR patient had mitral regurgitation patient coexistent mitral regurgitation with mitral myocardial infarction. They had an abysmal prognosis. And if you look at the functional MR, so functional MR also bad. The green ones are the one with severe MR. And if you look at the overall 1 year, 3 year, 5 year, 10 year survival, please look at this green one with severe MR, 5 year, almost 50% survival. So this is bad news, and we cannot let it continue like that. Same thing with the CABG patients. If there is functional MR and you leave it alone during the time of the coronary artery bypass surgery, you may be okay at the time, but over time, in 5 years, the patients will soon be coming back with bad heart failure, functional MR. And here, the concept of afterload reduction, the vasodilator and hydralazine, you know, you can buy time, but if the mitral regurgitation is progressing and the LV is dilating and then patient is getting worse, then you need to address that. You can buy time with the control of the atrial fibrillation, and you can give anticoagulation, and diuretics, we all know, is just the temporizing issues, decongestion, no impact on survival at all. So echocardiogram, we need to follow up if we buy time, unless there is a mechanical prosthesis, and we don't give routinely any, for just native valve MR, we don't give any antibiotic prophylaxis anymore. So asymptomatic is a challenge unless the center is good enough to do mitral valve repair. The replacement actually is bad. So you need to, in case of asymptomatic mitral regurgitation, which is primary mitral valve regurgitation, I would argue that don't send the patient for any surgery unless the center is good enough for doing repair, not replacement, because replacement will impact the prognosis of the patient. On the other hand, these are the staging of the mitral, the mitral valve regurgitation. Same. A means susceptible patient. B means patient has developed mitral regurgitation but not severe. But you need to see the progression. Clinically, you are obligated to monitor. C means patient has developed severe MR and then has normal LV function or poor LV function and maybe symptomatic. And then if that is symptomatic with severe, then they go to a stage D. A stage D is irreversible. Basically, going to a stage D is one-way ticket, and that is something we need to think about. And the prognosis can be uniformly bad. So mitral regurgitation, as I told you, we need to identify, is it degenerative or primary, or is it functional because of the LV remodeling? In the case of primary, you can quantify the mitral regurgitation, you can see the patient is symptomatic, and then LV dysfunction. LV dysfunction, that means contractility has gone down, and then LV systolic dimension is poor, and pulmonary hypertension has developed. All these, including the development of atrial fibrillation, all these will tilt you towards intervention for the mitral valve. And you can do that by surgically, and in suitable candidates, you can do percutaneously with the mitral clip. Repair in the presence of normal function and asymptomatic but severe, please do consider for mitral valve repair, because that is the way to improve survival. So with that, I will go and show this case. Asymptomatic 45-year-old male, routine exam, and you hear this significant murmur with thrill, 4/6 murmur with thrill, and then murmur becomes louder with transient arterial occlusion, and then moves earlier in systole with standing from squatting. These are all maneuvers you know very well to assess the severity of the murmur. And the EF is normal. And what is the most appropriate course of action in this patient? So the start ACE, repeat echo, start nifedipine and repeat the echocardiogram in 1 year, mitral valve repair, mitral valve replacement. Nifedipine, in case of aortic regurgitation, was studied in the NIH trial, and there was some suggestion that you can delay the surgery with the nifedipine because it causes reflex tachycardia, and the diastolic regurgitation of the AI can be altered a little bit and can buy time. So any comment on any of this?
Dr. Khairul Islam. Dr. Khairul Islam, please
Dr.
give
Khairul
your
Islam.
opinion.
Thanks for the volunteering.
Dr. Khairul,
So,
Dr. Khairul, unmute করেন একটু প্লিজ। আপনি একটু আনমিউট করেন। ওকে, এনিওয়ান? ডক্টর খায়রুল মোস্ট প্রবাবলি স্টাডি হয়ে গেছে একটু। আর কেউ?
হ্যালো।
হ্যাঁ,
হ্যালো।
হ্যাঁ বলেন।
হ্যালো, আসসালামু আলাইকুম।
yeah.
ওয়ালাইকুম আসসালাম, আমরা শুনছি, প্লিজ বলেন।
In this question, asymptomatic patient being seen for routine physical examination start, what is the most appropriate course of action? The murmur becomes louder with transient artery occlusion. I want to start an AC inhibitor and repeat the echocardiogram in 1 year.
What's that? Oh, okay. So you are choosing A. I would not disagree too much, but the most appropriate course of action, actually the answer is that if possible, think about mitral valve repair. But I think the A and C, I will take both correct. Nifedipine is not a good idea, and the mitral valve replacement is a horrible idea because in this patient who is asymptomatic, severe MR, but if the patient comes back with mitral valve replacement, his survival is compromised. So I think if the patient has, in this case, the blood pressure is 110/85, this exam is for the cardiology board here. But I would definitely choose A if the blood pressure was 140/80. That means you have room and you can give ACE and then give these follow-up in 1 year. But the ideal answer is mitral valve repair, because basically the theme remains that, yes, you can buy time, but it is already severe what you are waiting for. And if you have a center of excellence that can do mitral valve repair, it is better to go for that. It's a little controversial, but I just put this question in here to let you know that be aware about the mitral regurgitation. Be aware that this is not a benign disease. And if we leave this patient, he's 45-year-old. If we leave him alone and don't do follow-up, he's going to do worse over time. And then once he develops symptom, his survival will be compromised if we leave untreated, even after developing symptom. So, any other comment?
Thank you, sir. Thank you.
স্যার আরেকজনের একটা কমেন্ট আছে স্যার এখানে।
Yeah, definitely.
Sir, is there any concomitant mitral valve prolapse?
So, if there is, remember this patient did not have any transesophageal echo. So when, if there was a answer, say that E, C is mitral valve repair, D is mitral valve replacement, and E, do a transesophageal echo to evaluate, I would opt for that one, because when there is severe mitral valve regurgitation and there is prolapse, then you need to define what type of prolapse, what scallop is involved, and typically that scallop is P2 scallop. But this question is from the cardiology board, and remember in the question, if you pay attention, there is a mid-systolic click. So the examiner actually is giving away the diagnosis. The mid-systolic click is a hallmark for mitral valve prolapse. And this is the mid-systolic click, left systolic murmur, and the maneuver. It is actually very much suggestive of almost diagnostic of Barlow's. And in Barlow's, the P2 is the scallop. So that's why they did not give the TE. They kind of expect that you know this and suggest mitral valve repair.
থ্যাংক ইউ স্যার। আরেকটা কোশ্চেন আছে স্যার, বেশ ইন্টারেস্টিং কোশ্চেন। স্যার রিউমেটিক মাইট্রাল স্টেনোসিস তো কমন, কিন্তু রিউমেটিক অ্যারোটিক স্টেনোসিস কমন না কেন স্যার?
very interesting, but we don't know exactly why. And now, even in the mitral stenosis from rheumatic valve in the US, I tell you, we see about 1 or 2 a year. But it is interesting that even, and I'm sure that rheumatic valve disease has significantly dropped in Bangladesh. But going back 20 years ago, it is true, I agree with your observation that the coexistent aortic stenosis was not that common with rheumatic mitral valve stenosis. And in acute myocarditis with rheumatic fever, it is more likely to see regurgitation rather than stenosis. I cannot answer that question, that why it is not that common.
স্যার আমি লাস্ট একটা কোশ্চেন নিচ্ছি স্যার, আমাদের মাঝে আমাদের সবার প্রিয় ডক্টর রফিক আহমেদ স্যারও জয়েন করেছেন। আমি স্যার লাস্ট একটা কোশ্চেন নিয়ে স্যার আমরা আজকের শেষ এন্ডিং এ চলে যাব স্যার। কোশ্চেনটা স্যার বেশ, আপনি স্যার অবশ্য অলরেডি আনসার করেছেন স্যার, তারপর আমি একটু শুনতে যাচ্ছি স্যার। স্যার অবশ্য এটা স্যার এক মিনিট স্যার, জাস্ট চ্যাট বক্সে একটু দেখে নিন স্যার, এটা চ্যাট বক্সে ছিল স্যার কোশ্চেনটা। স্যার লাস্ট কোশ্চেন স্যার, ডক্টর মোহাম্মদ রেজাউল করিমের কোশ্চেন। আসসালামু আলাইকুম স্যার, হোয়াট ইজ দ্য লাইফ এক্সপেক্টেন্সি অফ সিভিয়ার aortic stenosis patients who can't afford intervention or surgery? How can we minimize the complications? What's the latest consensus regarding penicillin prophylaxis in MS due to CRHD?
Okay, so last question is
yes sir, last question.
We know that there is a routine use of antibiotic not recommended. However, this latest guidelines on the antibiotic prophylaxis has been challenged in Europe now, and there is a recent publication that following that guidelines there is a little bit increase in the bacterial endocarditis. But currently we are not giving, right? There are only 4 categories for giving antibiotic prophylaxis now. That means previous endocarditis, mechanical valves, then transplant vasculopathy, and then patient with cyanotic congenital heart disease, and the shunt. So otherwise routine indication is not there. We don't do that for transesophageal echo, and we don't recommend for any endoscopic procedure either. Now, the first question is that the aortic valve, I mentioned that in the natural history, that the development of angina, syncope, and heart failure. Heart failure is the worst, with the prognosis about 2 to 3 years, patients see death. On the other hand, if you do the valve replacement, there is a significant improvement in survival. In the partner B trial, where the patients were inoperable, the survival benefit was for 2 years, 1 in 5. The 1 in 5 patients did live longer for 2 years compared to inoperable patients. If you look at the partner A, the survival benefit was same with surgical AVR and catheter valve replacement patients. And if we look at the cohort now, as we are analyzing more with the TAVR and the SAVR patients, then if there is no significant comorbidities like malignancy, in the absence of those, the survival, 5-year survival is pretty impressive in these patients. Does it answer the question?
Yes sir, thank you sir. Sir, last আরেকটা কোশ্চেন স্যার, mitral regurgitation পেশেন্টদেরকে কোনো এক্সারসাইজের অ্যাডভাইস করি কিনা, বা কোন এক্সারসাইজ অ্যাডভাইস করব? ডক্টর তৌসিফ ইবনে আহবাবের কোশ্চেন।
So I tell you, exercise in general in cardiology is recommended, particularly, I'm definitely taking it that you are talking about chronic mitral regurgitation. So anybody doing any functional activities which the patient can, then operative risk goes down. Meaning that if you take the same mitral regurgitation patient and the patients have functional activity is horrible, bedridden. Their perioperative course versus somebody who can do some exercise, some walking, some functional class, their perioperative prognosis is good. So it tells you two things. One, it is already pre-decided that somebody is bedridden, no scope for any functional activity anyway. So they are already pre-selected bad. On the other hand, somebody can do some functional activities, actually alters the perioperative course.
Thank you
So,
very much, sir.
I
you,
take
sir.
common sense approach that
আমরা
do
স্যার আর কোনো
whatever you
কোশ্চেন
can. Yeah.
জি স্যার, আমরা স্যার আর কোনো কোশ্চেন নিচ্ছি না স্যার, যদিও আর অনেক আছে স্যার। আমি স্যার এখন আজকে অনুষ্ঠানে আমাদের প্রধান অতিথি প্রফেসর মাহমুদ হাসান স্যারের কাছে আজকের সেশন সম্বন্ধে তার অনুভূতি জানতে চাচ্ছি।
ধন্যবাদ ডক্টর এহসানুজ্জামান সাহেব। আমি প্রথমেই ধন্যবাদ জানাচ্ছি বিডি ফিজিশিয়ানসকে এই ধরনের সেশন সিরিজ হোল্ড করার জন্য। আর প্রফেসর চৌধুরী আহসান সাহেবকে অত্যন্ত হাফিজুল আহসান সাহেবকে অত্যন্ত ধন্যবাদ জানাই যে খুব সুন্দর ইলাস্ট্রেশন, কেস ইলাস্ট্রেশন দিয়ে উনি যেভাবে এটা বুঝিয়ে দিলেন, তাতে শুধু কার্ডিওলজিস্ট নয়, যারা কার্ডিওলজিতে ক্যারিয়ার করবেন না তারাও আমি মনে করি যে যথেষ্ট উপকৃত হয়েছেন। এবং এইভাবে আমাদেরকে সমৃদ্ধ করার জন্য আমরা অত্যন্ত কৃতজ্ঞ। এবং উনি বরাবরই আগেও করে আসছেন এবং ভবিষ্যতেও করবেন বলে আশা রাখি। এবং সঙ্গে সঙ্গে ডক্টর রফিক আহমদ সাহেব, উনিও একইভাবে আমাদের সাহায্য করে আসছেন। দুজনকেই ধন্যবাদ এবং যারা স্পন্সর করেছে তাদেরকেও ধন্যবাদ জানাচ্ছি। জি, থ্যাংক ইউ।
জি স্যার, আজকে আমাদের স্পন্সরশিপ আছে স্যার এসজে ইনোভেশনের ইএমআর, আমাদের আজকের অনুষ্ঠানের চেয়ারপারসন। আসলে স্যার আজকে এই পুরোটা সেশন আয়োজনের পিছনে কিন্তু প্রথমে কৃতজ্ঞতা আমি প্রকাশ করবো প্রফেসর মাহমুদ হাসান স্যারের কাছে, কারণ প্রফেসর মাহমুদ হাসান স্যারের মাধ্যমে আমাদের ডক্টর রফিক আহমেদ স্যারের সাথে পরিচয়, এবং ডক্টর রফিক আহমেদ স্যারের মাধ্যমে আজকে আমাদের এই সেশন। আমি আজকের অনুষ্ঠানটি সমাপ্ত করার আগে যদি চৌধুরী এইচ আহসান স্যার তার কোনো কনক্লুডিং কমেন্ট করেন, তারপর আমরা চেয়ারপারসনের মাধ্যমে শেষ করব।
So I'm looking at some questions. Sorry, I could not keep up with the questions. There is a question on the murmur severity and intensity of the murmur and AI. I will cover that in the second part of the lecture when I talk about the aortic regurgitation and mitral stenosis. But the other question is interesting, that coexistent CAD from the severe AS, how do you define that? Yes, we always do ischemia workup, which is cardiac catheterization, and define whether there is any coexistent severe coronary artery disease, because routinely for TAVR, or for that matter TAVR, we address the coronary artery disease, significant left main, LADs, circumflex disease or not. So we will also find that out before we do the intervention. Hope that answers the question.
থ্যাংক ইউ স্যার। আমাদের আসলে অনেক কোশ্চেন আমাদের লাইভ গ্রুপগুলোতেও ছিল, কিন্তু স্যার যেহেতু এটা আমাদের একটা আরো পার্ট আমাদের বাকি আছে স্যার, আমরা আশা করি তখন কোশ্চেন আনসার বাকিগুলো নিব। আমি স্যার আজকে অনুষ্ঠান এখন কনক্লুড করার জন্য আমাদের সবার প্রিয় ইন্টারন্যাশনাল রিপোর্টেড ইলেকট্রোফিজিওলজিস্ট ডক্টর রফিক আহমেদ স্যারকে আহ্বান জানাচ্ছি।
থ্যাংক ইউ। আমি সরি যে প্রোগ্রামটা মিস করছি, আমি আমার ক্লিনিক ছিল। তো হাফিজকে ধন্যবাদ এটা পার্টিসিপেট করার জন্য। হাফিজ আমাদের মাহমুদ ভাই অবশ্যই বলছে, কিন্তু হাফিজ is one of our proud sons. Not only that he has made us proud in America, but he has been going to Bangladesh regularly and training physicians and passionately involved in the development of medical field. আর আমি সবাইকে একটা কথা বলি যে হাফিজ আছে, মাহমুদ ভাই আছেন, আমরা আছি, আপনারা যারা ভবিষ্যৎ জেনারেশন আছেন, প্লিজ মেক শিওর দ্যাট উই টেক কেয়ার অফ দ্য কান্ট্রি। আমি কালকে একজনের সাথে কথা বলতেছিলাম যে আমি বাংলাদেশে মাসে 10 টাকা বেতন দিয়ে মেডিকেলে পড়ছি, and we owe many things. I owe my presence in America to Bangladesh and the country what has done. So whatever we are doing is not any generosity on our part. It is a duty that we are trying to follow, and I would request our future generation who outside the country, in the country, to please do that. Thank you very much.
Sir, thank you very much, sir. Thank you to the speaker. Chowdhury Ahsan sir. Thank you to today's chief guest, Professor Mahmood Hassan sir. And thank you to today's chairperson, Dr. Rafiq Ahmed sir. অনেক লাইভটা ক্লোজ করে দেবো, আমরা একটু 2-1 মিনিট কথা বলি।
Thank you.